The best way to read a glucosamine chondroitin bottle is as a symptom experiment, not a cartilage construction contract. These compounds are related to cartilage matrix biology, and osteoarthritis does involve cartilage breakdown, but pain is produced by a whole joint system: bone, synovium, swelling, muscle strength, load, and nervous system sensitivity. That is why some people report less knee pain while the big evidence picture stays mixed.
So when people say, my joints need building blocks, what are they actually swallowing? Are glucosamine and chondroitin nutrients the body can simply route straight into worn cartilage? Or is that too clean of a story? And why do studies seem to disagree so much? Is part of the confusion that glucosamine can mean sulfate, hydrochloride, combined formulas, different countries, different product quality, and different knee pain populations?
Exactly. Mechanistic plausibility is the first rung, not the finish line. Glucosamine is involved in molecules used in cartilage and joint fluid. Chondroitin is part of cartilage's water-holding matrix. But osteoarthritic cartilage is not a passive sponge waiting for parts. Cells are inflamed, mechanical load is altered, and surrounding tissues contribute to pain. So the honest mechanism claim is may influence joint environment, not regrows your knee. The most defensible upside is modest symptom improvement for some people with osteoarthritis, especially knee osteoarthritis. Recent reviews and trials include positive signals, including common combined daily doses around 1,500 milligrams glucosamine and 1,200 milligrams chondroitin, but the response is not guaranteed. A good result is not new cartilage on command. It is less pain with stairs, easier chair stands, or less morning stiffness after a fair trial.
Who is the fairest candidate then? Someone with mild to moderate knee osteoarthritis who is already doing strength work and weight-aware joint care, but still wants to test whether a supplement adds something?
Yes, with one hard boundary. Do not use a supplement trial to explain away a joint that needs evaluation. Severe swelling, a hot joint, locking, major trauma, rapidly worsening pain, fever, or a sudden inability to bear weight belongs with a clinician. Osteoarthritis usually changes slowly. A sudden new pattern might be injury, inflammatory disease, infection, gout, or another problem, and that is not a supplement aisle decision.
If someone is an appropriate candidate, how long is fair before they judge it? 12 weeks? 6 months? And what should they measure so they are not just remembering the best day and calling it science?
I like a 12-week minimum for a first-pass symptom test because several studies use that kind of window, and longer studies often look at 6 months. Pick 3 metrics: average pain during a normal activity, stiffness after rest, and a function task like chair stands or walking distance. If nothing meaningful changes by the agreed date, the supplement has had a fair chance. Continuing forever because it might be protecting cartilage is where evidence compression becomes marketing. Another reason to track function is that exercise itself improves many OA outcomes. In a recent randomized trial, nutrition supplementation plus supervised exercise improved some knee OA measures earlier than exercise alone, but both groups improved over time. That tells us something practical. Supplements may be an add-on for selected people, while muscle strength, balance, flexibility, and load management remain the machinery that changes joint stress every day.
The caution I hear most is blood thinners. If someone takes warfarin, is glucosamine or chondroitin something they can casually add? Or is that a call to clinician situation before the first capsule?
That is absolutely a clinician call. Warfarin interaction concern is important enough that natural is the wrong mental category. People should also be cautious if they have shellfish allergy concerns, diabetes, pregnancy, or upcoming surgery, because product sources, blood sugar questions, perioperative bleeding planning, and limited pregnancy safety data all change the risk-benefit calculation. Most users tolerate these supplements, but the exceptions are exactly where a simple experiment becomes medical coordination.
Can people get a meaningful dose from food instead of pills? Or are we mostly talking about extracted supplement ingredients, where the more important food advice is general joint health context rather than eating some magic cartilage meal?
For dosing, The common research pattern is roughly 1,500 milligrams glucosamine and 1,200 milligrams chondroitin daily, often divided or combined, but products vary. A practical buyer should avoid megadose improvisation. Use a reputable product and not stack multiple joint formulas that duplicate ingredients. If stomach upset, rash, unusual bruising, or any concerning symptom appears, stop and reassess, especially if other medications are involved.
So the clean takeaway is not take it or trash it, right? It is, if you have appropriate osteoarthritis symptoms, no interaction red flags, and you can afford it, a tracked trial may be reasonable, but the winning standard is better pain or function, not faith that a bottle is rebuilding cartilage while the rest of joint care gets ignored.